recognizing and thanking our partners and sponsors, and you can see them listed here. I like to always put in a good plug for the Dana-Farber Cancer Institute. We are here at the Dana-Farber Cancer Institute in Boston, Massachusetts, where we have been holding meetings since 2003. Think about that. That's 15 years. So thank you, Dana-Farber, and thank you to all of our other partners and sponsors. I want to remind everybody that on September the 13th and 14th in Washington, D.C., we will host our 14th annual African American Prostate Cancer Disparity Summit. That's an event that we started back in 2005, and it is an event that's free and open to the public. I want to make sure that everybody understands that. Our first day will be at the U.S. Capitol Building in the Visitor Center, and the second day will be at the Washington Convention Center. And you can go to our website, www.rapcancer.org, to get more information about the summit. But we invite those of you who are able to join us to come out and join the summit. We have a very, very exciting program for 2018. And those of you who are not able to join us in Washington, we will stream the complete program live. So you will be able to join the program in Washington, D.C. or online. So you have no excuse. Come and join our annual summit. And for tonight's program, I always like to remind all of you who are tuning in that you are able to join the conversation. We have a good audience here in Boston, and they raise their hands and they have microphones, they ask questions. You have your keyboard, so you can email your questions to, as you see here, or use Facebook or Twitter. And we will make sure that our presenter answers your question as if you were here with us in Boston, Massachusetts. Now, I want to introduce our guest speaker, Dr. Barneswell. Dr. Barneswell is a presenter who has worked with Finn in the past. Is another one of our programs in New York. So we are very, very pleased to have Dr. Carlton Barneswell with us. Now, Dr. Barneswell is a board-certified urologist serving the community of Elmont, New York. He attended Yale University, where he received his medical degree in Masters in Public Health with distinction, and completed his internship in surgery at Boston University. Dr. Barneswell completed his medical internship at Cabrini Medical Center. He continued his training by completing a residency in surgery at St. Luke's Roosevelt Hospital Center. He also holds a bachelor's degree from Wesleyan University. Dr. Barneswell is a part of Advanced Urology Centers of New York, Elmont, and is affiliated with Long Island Jewish Medical Center in New Hyde Park, New York. He is board certified by the American Board of Urology. Dr. Barneswell's clinical interests include general urological screening and treatment with special expertise in prostate disease, including prostate cancer and BPH. He has treated and managed a diverse range of medical dysfunction and is committed to providing the best comprehensive medical care available. And this evening, Dr. Barneswell will speak on understanding the new prostate cancer treatment, erleada. And erleada is a treatment that's come out of a clinical trial called Spartan for a new indication for prostate cancer. And he will give you all the details about that, and I'm sure many of you who are here and tuning in will find this very informative. So I would like to now welcome Dr. Carlton Barneswell.
Thank you very much. It's a pleasure to be here. So, in my journey as a urologist, I have had the opportunity to treat a significant amount of prostate cancer. And in fact, the group that I'm part of, we treat approximately 2% of the prostate cancer in the United States and about 20% of the prostate cancer cases in New York. So this is something that's very important to us, and I'd like to tonight share what I see as the timeline or the continuum for prostate cancer. I'll discuss some of the epidemiology, which really basically reviews the incidence of prostate cancer. I'll also discuss screening and review the treatment options for prostate cancer briefly, and then talk about what we're really here to learn about today, which is a new treatment for people with prostate cancer who failed their initial therapy. So I'd like to, again, just review some of the objectives. We'll talk about prostate cancer, the initial symptoms. We'll talk about some of the symptoms that patients typically present with. We'll also talk about the role of androgens, testosterone, in prostate cancer. And then we'll talk about prostate cancer in men who failed primary therapy and who failed the initial treatment that we give in that space. So these are some of the thoughts and feelings that patients have when they develop prostate cancer. These are things that I see every day. So a lot of patients basically are scared, and some patients jump in right away and get very active. Some people get involved and review the literature, and now with the internet, they have access to a lot of information. And there are other patients who say, still today, doc, tell me what's best for me. So in general, there's a lot of, what I see is a lot of, there's a big gap of information for people who are diagnosed with prostate cancer and who sometimes feel hopeless, and they're not aware of all the options that are available at each stage. So what are the issues for patients? Patients are often confused about exactly what stage they are and what options are available for that stage. They're concerned about what the future holds for them. And they're also not sure about what happens when their disease progress. So let's talk a little bit now about the epidemiology of prostate cancer, the distribution of prostate cancer. So prostate cancer still, despite a lot of the controversy about screening for prostate cancer, it's still the number one cancer in men. It's about 164,000 cases projected for 2018. And if you look to the right, you'll see that prostate cancer is the number 2 cause of cancer death. So this is still a major problem in the US. And this problem is even more important depending on who you are, what ethnic background, and what race you are. So what we know about prostate cancer is that as you get older, the risk increases. Additionally, if you're African American, your risk is higher. It's approximately twice as high as whites. Where you're from makes a difference. For example, I'm from the Caribbean, so my risk is probably about triple what the risk is for whites, so even higher than African Americans. Family history is also important. We know that people that have family members should be treated as high risk and should be screened more aggressively as well. There's some other interesting information that we've gotten over the last few years. We've realized that there are certain gene mutations that exist in some families that may increase your risk of getting prostate cancer. So for example, if your female relatives have ovarian or breast cancer, they may have a genetic mutation, the BRCA mutation, and you may also be at risk for prostate cancer. So you may have to be screened and looked at in a different light. So these are all the new types of things that we weren't able to appreciate in the past when we basically just screened everyone. Finally, there are other factors that may play a role that we certainly need to do some more work on. Your factors like obesity, your other things like diet. All of these are issues that may play a role as well. So one of the questions that patients often say to me is, when I tell them that they have prostate cancer, is, but I don't feel anything. So the question is, what are the symptoms of prostate cancer? As many of you know, most patients with early stage prostate cancer have no symptoms. So that makes it a little bit more difficult to encourage people to get screened for prostate cancer when it's like blood pressure. You don't feel anything. So the question is, well, why should I do it? Well, I'd like to take you back to that second slide that I showed. That really early stage disease. The symptoms that may be associated with prostate cancer include problems with urination, hematospermia or blood in the sperm, and there are cases of erectile dysfunction also that may be related to prostate cancer. Now, one important point that I want to make about symptoms: bone pain, back pain can be a sign of prostate cancer. Prostate cancer, one of the most common sites for metastases involves bones. And this can vary from pain to sometimes getting what we call can lead to paralysis. So pain is an important symptom that can present with prostate cancer. I alluded to this a second ago. Again, you can get a weakness in the lower extremity if you have involvement of the spinal column. So when we talk about screening for prostate cancer, we always talk about PSA. So what exactly is PSA? So PSA is a protein. It's called a serine protease that is really changed the fabric of American medicine and basically changed prostate cancer. Prior to PSA, most men with prostate cancer, about 80%, presented with metastatic disease. In this era, because of screening, now the converse is true, that we actually find more men with early stage prostate cancer because of screening. So PSA is a protein. It's produced by cells in the prostate and is mostly found in semen. The chance of having prostate cancer increases with PSA level. So I just want to make a couple of important points about this. So we're accustomed to having a threshold, and if you're above that threshold, you may be at risk for prostate cancer. Also important is the kinetics or the change of PSA over time. So that basically means that having your PSA checked and knowing your PSA is important, because if it's going up too rapidly, even though it's below what's considered a normal level, you may still be at risk for prostate cancer. So most men shouldn't have their prostate cancer checked, especially the men that are high risk, men with family history, African American men, Caribbean men, etc. And knowing the behavior of your PSA is important. So what other tools do we have for screening for prostate cancer? So many of you are familiar with the digital rectal exam, or the DRE. Patients often say, well, what exactly do you feel when you feel the prostate? So when we insert our finger in the rectum, the prostate generally feels like a smooth, rubbery texture. If on both sides, if one side is higher or asymmetric, you need a biopsy. Additionally, you may feel a lump or a nodule, a bump. If your prostate cancer blood test is normal and your exam is abnormal, you need a biopsy. That's a very important point. So there are men with prostate cancer who may have a normal PSA test and it's found on the DRE. Okay, very important point. So these are the two cornerstone tests that we use for screening for prostate cancer, the DRE and the PSA. Now there are different guidelines and different recommendations for different groups, which are published, and you can look at what is mentioned for your group. I want to say this emphatically. For African American men, some of the guidelines say you should discuss it with your doctor. there are some important points that is very important for you to remember. Because of the increased incidence in African American men, screening should be started earlier. It should not start in the 50s. Additionally, the screening, having the second component, the digital rectal exam, is also an important part of screening. Okay, that's very, very important. Some people feel that they're adequately screened when they have only the PSA blood test. So you should have both tests in order to be appropriately screened. So what happens if your PSA, your DRE, your digital rectal exam is abnormal? So that then basically says, okay, there's a risk of prostate cancer, so how do we go about diagnosing prostate cancer? So the way we do this is basically by using what's called a biopsy, which is done by taking pictures, both MRI and ultrasound, to do the biopsy. But the biopsy, when done with ultrasound, is usually the first step. So these are the key points that I'd like you to remember. Prostate cancer is still a very important cause of cancer deaths. Patients with early prostate cancer may have no symptoms. So when you have symptoms, it may indicate more advanced disease. So it's really important for asymptomatic men to get screened for prostate cancer. And for men at high risk, African American men, Caribbean men who have double or triple the risk, screening is an excellent idea and should be done as part of your routine physical examination. Lastly, there are a lot of different organizations and different guidelines that disseminate information, such as this organization. And it's important that all of us get involved in educating ourselves about screening for prostate cancer because we're most impacted by it. So the question is, are you familiar with both the PSA and DRE? Are you getting it? Do you know your level? How often should you have your PSA checked? So most experts recommend that you get the PSA and the DRE once a year. And you should pay attention to how the level changes over time. My PSA is 0.7. I'm very proud of that because I tell my patients that I'm getting the PSA test just like they are. So what do you guys think an elevated PSA indicates? Does it mean you have cancer? Exactly. So there are different reasons why you may have an elevated PSA. Having a large prostate may contribute somewhat to your PSA level. Ejaculation slightly elevates the PSA. Inflammation can also cause the PSA to be elevated. So typically, when the PSA is elevated, we repeat the level, and if it's consistently elevated, then we need to proceed to do a biopsy to make sure there's no cancer. So when we talk about prostate cancer, I mentioned that it's really a timeline. And I mentioned that when we attempt to find prostate cancer, we try to find it in the early stage. Because if we don't find it in the early stage, it can progress. And when you're later on the timeline, on that continuum, it's much more difficult to treat. This has caused a lot of concerns. And we, in general, have emphasized screening so that we can find prostate cancer early. However, I want to say that for men that have more advanced disease, it's also important for them to be evaluated and treated because of the different options that we have available. So in that regard, what really drives prostate cancer? What's the fuel for prostate cancer? So many people don't know this, but the drive for prostate cancer is actually hormonal. It's androgens. It's testosterone. So testosterone can promote prostate cancer growth. So what's the mechanism for this? Well, in simple terms, it's like taking a key and put it into the lock. So the cells have what are called receptors, and these androgens, the testosterone, will bind to those sites and stimulate the growth of the cancer cells. So this is the basis for the continued growth of prostate cancer cells, and we can exploit this in order to create treatment options for people with advanced disease who we don't have the opportunity to cure. So we know that the body naturally produces these hormones called androgens, primarily testosterone, but they're very important for us for a lot of different things in the body. However, they can also fuel prostate cancer growth. So in patients with advanced cancer, the most important part of controlling people with cancer that's no longer curable by surgical extirpation or radiation is to block testosterone. So we call this androgen deprivation therapy, or ADT. Are you guys familiar with this, with testosterone and the role it plays? So this is probably a new concept for many of you, because we spend a lot of time emphasizing treatment for localized disease. But for people with more advanced disease, the primary treatment again is to give medical or surgical therapy to block testosterone. Okay, so this is a new concept, but now has become very important. Why? Because when we treat men with androgen therapy, or ADT, eventually some men will escape from that. So let's just talk for a brief moment about what we do for people with localized disease, and then we'll talk some more about people with advanced disease. So you guys are all pretty familiar with this. You know that for patients with localized disease, if it's low grade, there are some people who elect to watch the cancer or do what's called active surveillance. What that means simply is we do periodic or interval PSAs, digital exams, MRIs, and biopsies to reassess if the cancer is progressing. There are patients who are not as healthy, who don't plan any intervention, and they basically just do what's called watchful waiting. What else do? We also do surgery. We do robotic prostatectomy, we remove the prostate, or we do what's called brachytherapy, or seeds, and radiation. So these treatments affect the DNA in cells and destroy cancer cells. So those are the treatments that we give for localized therapy. So for people with more advanced treatment, who require more advanced treatment, again, the cornerstone is anti-deprivation therapy. So we either surgically or by medication give therapy to block testosterone, because that fuels the growth of prostate cancer. So the way we evaluate patients is we treat them definitively, and if they fail that, we reassess where they are. We so-called restage them. So the question is, what stage are you? Did your cancer spread? So the important point when you're at this place is, one, you failed definitive therapy. We put you on anti-deprivation therapy. Again, we want to block testosterone. And we follow patients with their PSA. We look at your PSA, and we see that your PSA initially goes down, and we continue that therapy. But for those patients, eventually, the cancer will escape, and the PSA will start to rise. So what we do at this point is we check to see if the medication that we're given, or the surgical therapy that we gave, is really effective. And the way we're able to do that is to check testosterone. If testosterone is low, so we know the medication should be working, and we see the PSA simultaneously rising, we know that we need new intervention. So what I just described to you is called non-metastatic castration-resistant prostate cancer. So let me explain what this really means. So what this means is we've treated you. So we've given you radiation, we've given you seeds, we've done surgery, or whatever the treatment, and if your PSA is stable, fine, we continue to tell you, come back and we do interval checks. For some patients, the PSA will start to rise. So we'll know they have failed, okay? So now we restage them. We don't see any evidence of any cancer on their x-rays, but we know that there's cancer somewhere because their blood test, their PSA is rising. So what do we do? What did I say was the first line of treatment? Blocking testosterone. So we block testosterone. So these patients are now sensitive to the blockade of testosterone. Their PSA goes down. And then it starts to rise after a certain interval. So now they've escaped that initial treatment, that initial what we call ADT. So they have no evidence of metastases. Their x-rays are still negative. They're castration resistant because the initial anti-deprivation therapy that we did, the testosterone blockade, worked, but now they've escaped it. So then they're resistant to it. So they have no evidence of metastases, and they're resistant to the initial treatment of blocking testosterone. Okay, so hopefully that's clear. So until recently, this was a big problem. So where are the places where we should look for prostate cancer metastases or spread? Well, virtually anywhere. So typically, as I mentioned earlier, you can see spread into bones. It can also spread into lymph nodes, liver, lungs, and even in the nervous system, in the brain. So these are all sites for metastases. So we would, again, always do x-rays to check to make sure that we don't find any places where there are metastases. So if you're at this point and we find metastases, we've had treatments for that. But specifically, until now, we've not had any treatments for people who had, no evidence of spread, but your PSA is rising, and they failed the initial testosterone blockade. This was a big problem because what we did until recently was keep doing more and more x-rays and really not having an option to offer these patients. So some of you may be in this position and you may be familiar with the agents that we give for testosterone blockade. Anybody know the names of any of these agents? Yes, Leuprolide or Lupron, Eligard, Vantus. These are all different agents that are used. And there are some patients that we do surgical treatment by removing the testicles, which is basically the production site for testosterone. So again, the ADT, the anti-deprivation therapy, by those agents that we just described, the goal is to block testosterone from having its effect on the prostate cancer cells. So this new era that I just mentioned, so I said until recently, men specifically who had definitive therapy and failed, and then what's our go-to once that happens? What do we do next? We give testosterone blockers, right? Anti-deprivation therapy. And what happens after that? The PSA goes down, so we know that those people are doing well. Subsequently, what happens after that? The PSA starts to rise. So we do scans, x-rays, to see if there's metastatic disease. And in those patients, if we don't find any metastases, until recently there were no adequate treatments available for them. And we would wait until they develop metastases until we could treat them. So now we have something that's new for these patients. And this is very exciting. So erleada or apalutamide fits this need. So this medication is used specifically to treat men the men that I just described, who have a PSA that's rising. They initially got the anti-deprivation therapy, the ADT. They responded, but now their PSA starts to rise. And when we do x-rays to determine whether or not they have metastases, we don't find any. So until recently, we had no options available for these patients. So now we have erleada, which was approved by the FDA specifically to treat these men. So erleada basically also exploits the same mechanism of action as the other blockers. Instead of blocking production, it blocks at the site where the testosterone interacts with the prostate cancer cell. So what are the side effects of erleada? So some of the side effects that you may feel include tiredness or fatigue. You may have joint pain, diarrhea, weight loss. There may be edema, swollen ankles, or changes in blood pressure. There's also a possibility of getting a rash, which is a different type of rash than what we see from typical allergic reactions. And there may be an increased risk of falling. Two things that we highlight when we talk about erleada is the risk of falling, testosterone, and whenever you use any type of anti-deprivation therapy, testosterone is important for bone health. So it's important to have bone therapy, and patients, some of you in the room may be in that position where you're taking the leuprolide or one of those other agents and you're getting bone therapy. But patients, whenever you manipulate the androgen receptor, that is always a concern. And specifically for erleada, we have to be concerned about falls and fractures. There are, I think, 2 people in the trial who had seizures. So we also highlight that and tell you that if you're at risk for a seizure, you should discuss that with your doctor if you're a candidate for erleada. So this drug was, the data for it was published in early February, and mid-February it was approved by the FDA. And the evidence for its use is overwhelming. There are a lot of different organizations that publish guidelines on how to manage patients for all different disease entities. So the different organizations for prostate cancer treatment have included erleada now in their guidelines for use in men who specifically have the condition that I outlined. They've received primary therapy, they failed, we put them on the hormonal blockers or the androgen deprivation therapy, the ADT. Their PSA went down and then it started to rise. And we say, okay, maybe they've now developed metastases. We do x-rays and there's no evidence of metastases. So for this specific group of patients, we now have erleada to add to our armamentarium. So, takeaways before I open up for question. I want to restate so everyone is clear. Non-metastatic castration risk in prostate cancer. What are the important points? No evidence of metastases. They're castration resistant. What that means is simply that they initially got ADT and they responded, but now their PSA is rising. So they've escaped, if you will, the effect of the testosterone blockade. So with that clinical scenario, we know that long term, these patients, again, it's a timeline, may progress to develop metastases. So what's our objective? What's our goal? We want to specifically attempt to delay the metastases, or if you will, block the metastases. So the goal here is to give erleada for the purpose of delaying metastases, delaying the progression. Okay, so hopefully that's clear. So erleada is the first drug approved by the FDA for this specific criteria that I outlined. So this is something that if anyone is in this situation and you meet that specific criteria, you should discuss with your doctor to see if you're a candidate for erleada. So again, I mentioned this. If you have a history of seizures, if you may be at risk for a seizure, you should discuss it with your doctor. You should always tell your doctor in general across the board what are the medications you're taking. You should always take erleada, swallow it whole, don't chew it. There is a little desiccant inside the package to keep the moisture. Please leave it in place. You should also continue to take that initial drug that you took. So you take it in combination. So you're just adding erleada. So you're not stopping the initial testosterone agent, the one that was designed to block testosterone production. So usually that's given by injection. You should continue that and then add erleada. All right. You should keep it at room temperature. And as I said, again, you should keep the desiccant. Remember, pregnant women should not obviously touch or handle or ingest testosterone agents like this across the board. There are different agents that we recommend that they avoid touching. There's some other prostate medications that are in that space. So erleada also should not be ingested by pregnant women. If you are thinking about donating sperm, you should wait 3 months after you stop erleada to do so. So finally, as part of my discussion with all my prostate cancer patients, I give them a list of all what I call public websites, organizations where they can get information. So this is a nice list of different organizations where you can get information from about prostate cancer. I'm open to take all your questions and look forward to helping clarify any things that you didn't understand.
Blocking metastases. Does that mean the question is, the metastases, you said one of the points was blocking. Does that also mean elimination?
So the way the drug was, the study was designed, we gave, and pretty much all studies are done this way. We basically give a group of patients the drug and another group a placebo agent. And in the study that got this approved, there was a significant delay in the time of metastases. So I try to use simple words to make it clear, but that's basically what I wanted to say. So there was a significant time difference in the people who received the medication versus placebo. Very, very significant.
Could I get a few more details of how does a lever work?
So a lot of the agents for prostate cancer that you're familiar with, you mentioned some of them, they work by blocking testosterone production and release, and it's done in the brain. So without making it too confusing, the brain sends if you will, an agent to the testicles to make testosterone. This is controlled by a part of the brain called the pituitary axis, the hypothalamic pituitary axis. So basically what we do is we give an agent that will block the production of testosterone from the brain. Okay? So the signal isn't sent to the testicles to make testosterone. So we're blocking the production. Now, in the last few years, to try to make it simple, what we've done is we've looked at a different area, looking at the interaction locally at where the testosterone interacts with the cancer cells. And that's the picture that I showed earlier where the testosterone joins to that receptor. So what we know now is that if we can interrupt that blockade, we can get results from different agents, and erleada works in that fashion. So it's working not centrally in the brain and blocking production, but working locally. So that's sort of the simplest and clearest way to explain it.
That's good, because I hope that suggests that in the future we'll be able to see those cancer cells earlier. So I hope that's what we're going towards, because right now, because you can't recognize them, that's how they get metastasized. But if there's a point that we can recognize them, we'll be able to get rid of them earlier.
So that's a very sophisticated question. So again, it's a timeline. And some experts argue that, yes, if you don't see metastases, it doesn't mean you don't have metastases. that basically we just don't have the ability to detect it. So that is an important question, and there are different tests that we can use to determine if there's metastases. But you're right, they're not 100% effective, and we know that there are gaps because there are people who indeed have metastases and we're not able to detect it. What we do know is that the PSA level does correlate with our ability to detect metastatic disease. And one of the important points about this drug is looking at the way PSA behaves is important. So getting continued follow-up is very important because, again, if we see the PSA rising when it should be 0 from the blockade, the ADT, the anti-deprivation therapy, then we know that, yes, there's disease progression, quote unquote, just by the fact that the PSA is increasing. So since we don't have the ability to detect, we have to use what we have, and PSA becomes important in that space. So the test that we use, basically, in the past we used a test called a CAT scan and a bone scan. And more recently, we've used another test called Axumin. This is a PET scan that's used specifically to try to find prostate cancer in a setting like I described. PSA also is important in that setting because the higher the PSA, the higher the yield with the study. The take-home message and the point that I'm trying to make is, again, getting ongoing follow-up is important so that we can intervene as early as possible, because ultimately what we want to do is, if we can, to delay metastasis.
I have one other question. Earlier you said that men should always have the PSA and a DRE. Now, I'm a prostate cancer survivor, and I still get my PSA checked, but I don't get a DRE. Should I be doing that, and if so, why?
That's an excellent question, and different experts have different opinion. So I still do both. Two reasons. One, I have had patients who failed, and I felt a nodule. For example, in patients who've had their prostate removed, and I see the PSA kinetics. I see an abnormality in the way the PSA should be, and I feel something. And when I feel something, I've occasionally biopsied it, and, for example, radiated those patients and successfully treated them. So you should still get, in my opinion, the DRE. Also, in terms of rectal cancer, it's not a bad idea to do it also. So some experts say you can forego it after you've had the prostatectomy, but I think most people agree that you should.
How is this treatment different from Xtandi?
So
Is it better?
I can't say it's better. So what I can say is that recently there's another drug called Xtandi that was approved also for this space. And what I would say is, speak to your doctor to see which drug would be appropriate for you. I can't say it's better or worse.
Will it last longer? Most drug over time will fail.
So again, I think we have to remember what the goal is, and what I try to leave you with is this idea of this concept of this timeline, and whatever time you get from each medication is important, because that's going to add, in many cases, survival, but some other important things. Not having to take pain medication sometimes, not having to take chemotherapy sometimes, IV chemotherapy, I mean specifically, or other agents. So all of those things add up. The take-home message is, on the timeline of your treatment, the earlier you get treated, the better you do. So that should be the focus.
I have a question. The fact that testosterone, I guess, basically feeds the cancer. If you have not had a rising PSA for 15 years, what's the likelihood that that you would have a rise after 15 years?
You're talking about
I'm talking
before
about-
or after treatment?
This is after treatment.
Okay, so I'll answer for both. So the longer you go without a bump, and I like the word you use, the bump, the longer you go without the bump, the better you are. However, there are reports of people who have late recurrences even after 15 years. So the other question is a little bit more sophisticated, but I'll try to make it very simple. So there are different studies that show that if the PSA, when you're young, if you start out at a lower level, your risk lifetime is less. So that is true. However, I think especially in the high risk groups, we still see patients who have a sudden surge in their PSA, and therefore you should continue to get screened. So I want to make it clear, for both groups, you should continue to get surveillance to make sure, from the screening point of view, to make sure that you don't have prostate cancer, and for the treatment group, to make sure that you don't have a recurrence.
Dr. Barnwell, the question that I had for you is regarding the MRI biopsy that you mentioned with ultrasound. Could you please elaborate on that process?
Okay, so that's a important question. I tried to stay away from that, but I got pulled into it. Okay, so I want to make this clear. So MRI, the data suggests that MRI may not increase the yield of finding prostate cancer. And the way we use MRI largely is in patients who've had a regular biopsy. So we don't use MRI for screening purposes. We use it for people who've had a regular biopsy, and on their biopsy we see abnormal cells. That's called PIN, or high-grade PIN, prostatic intraepithelial neoplasia, or something called ASAP. These are abnormal cells that are not cancer. So if you have a biopsy and we don't find cancer, but we find these abnormal cells, we do an MRI, and if we see a spot, and we classify the spot depending on how likely it is to be cancer from 1 to 5. If it's 3, 4, or 5, we target that spot for a biopsy, because MRI may improve on finding more aggressive cancer, but it's not to be used as a screening study. So I've had patients who walk in and say, well, my PSA is I want an MRI biopsy, or can I use MRI to check to see if I have cancer? So it's not a screening study.
So just to follow up with that question, I've had the MRI, and I've seen they've discovered lesions or tumors, whatever you want to term it as, and so they said I should have a targeted biopsy. So that's where I'm at with my next step. So I just want to get some clarity.
Okay.
On
So
what
I'll
that-
clarify. Okay. So in a case like this, and I don't want to comment on your case in particular, but in general, if we see a lesion or a spot, and I use the word spot, on the MRI, if it's again, the category is 1 to 5. If it's 3 or higher, we would target that spot for a biopsy. Okay, if you're 1 or 2, we would continue to follow you, and there are additional tests that we can use to try to decipher whether or not you have prostate cancer. I also want to emphasize that if, for example, we do the MRI, so you have a high PSA, we do a biopsy, we find these abnormal cells. We do an MRI, the MRI is normal. So now we don't have something to target. So what should we do in a case like that? Many of those patients still need a regular biopsy because they still have an increased risk of having cancer. So if they have multiple pieces of PIN, or if they have a lot of abnormal cells, again, I'm trying to be simple, it's called ASAP, those people should have a follow-up biopsy. That's the take-home message. So the MRI is used specifically for something that we may target, but if we don't find anything on MRI, those patients still need a biopsy. Very important point.
I have a question. You're advocating repeated screenings, biopsies, MRI. Is there any danger after years of repeated screenings of this type?
So what I'm what I try to say is that clearly some people are more at risk. So there's reasonable data that suggests that men, there's a racial difference and a geographic difference. There's reasonable evidence that says that. So for example, if you go to the Caribbean basin and you look at the incidence of prostate cancer relative to what you see in white men here, clearly the incidence is about triple. So those are high-risk men. So in my practice, where I have a lot of Caribbean American men, men who were born in the Caribbean and came here, or Caribbean parents, I look at them with the idea that they may have an increased risk. Also, my African American patients or white patients with a family history. So the screening still has to be a discussion with the patient. So what we do is we tell them that you may be at increased risk, and the advantage to doing the screening is we may find cancer, and we may now also say, well, we can watch you. We can do surveillance. Or if we have the situation where we find aggressive disease, we can treat you. Versus if you don't do any screening and you have aggressive cancer and then you present with metastatic disease, then you may be in a more difficult situation. Again, the concept of the timeline is important. So I emphasize this is a discussion that should be between the patient and the doctor about the risk and benefits of screening. However, I think it's important that the doctor is also knowledgeable about the epidemiology of prostate cancer and can discuss the risks, benefits for those specific patients. Now, I've heard people say, if you do a biopsy, does it spread the cancer? So that's, I think, has been refuted. Basically, the bottom line is, if you look at the number of people who have biopsies each year and look at the people who get treated, most of those people still do well and are cured. If indeed there was spreading of cancer, you'd see much more metastatic disease. So, but I've heard patients in different forums like this ask about spreading and why we shouldn't do screening.
I just have one more question. What about diet? You didn't talk much about diet in terms of avocados, walnuts. There's various things that do help with prostate cancer. Do you talk to your patients about that as well as exercise?
So I do. I think that it's important to first highlight that we still need a lot more information about that. And we really need to emphasize to patients that we don't have specific proof that any specific thing will prevent prostate cancer. So I think there is some body of evidence that some things may be important. So I basically encourage across the board a healthy lifestyle, exercise and diet, and avoiding bad fatty acids, and encouraging people to eat good fatty acids. That's across the board. Also, refined sugar, refined flour, that sort of thing.
Let's give Dr. Boswell another round of applause. Thank you, sir. Thank you. Do we have a good appreciation now about non-metastatic prostate cancer? Do we understand that concept and what that is all about? Okay, excellent. It is, as a prostate cancer survivor and the head of FIN, I think anytime we get a new treatment, that's a good thing. And so erleada is a new treatment from Janssen. And so we want to thank Janssen for all the work that they've done and put in to bring us this new treatment. So thank you as a prostate cancer survivor, and most of us here are prostate cancer survivor. Our goal is to, as survivors, is to never die from prostate cancer, but make it a chronic disease so that we can live forever and maybe die from something else, and before maybe they find solution for that too, and we just keep on going. So that's the hope. So again, we want to thank Dr. Barneswell, and we want to thank Jansen for this presentation this evening. Let's give another round of applause. Now I want to talk about our events that are coming up. Early on, I talked about our 14th Annual Summit in Washington, D.C. That's September the 13th through the 14th. I think many of you are certainly aware that we launched our stage play this year. That is where we entertain to educate. It's been very successful. So Daddy's Boys is, we have 3 upcoming events, and they all seem to be in North Carolina, these 3 upcoming events. So you can look at that schedule, and you can go to our website to get more information. And for those of you who are tuning in, you can go to our website and register to attend those events. And I want to emphasize that all our events are free. Our summit is free. Our Daddy's Boys play are free. So it's part of our mission to educate about prostate cancer, to save lives. So we invite all of you all to these events. We will not have a webcast on September the 12th. And that's simply because if you look at our upcoming events, we have a summit on September